Hi, let's move on discussion of subarachnoid hemorrhage. Subarachnoid hemorrhage is bleeding into the subarachnoid space, which is created by blood accumulated there. The area between the arachnoid membrane and the pia mater surrounding the brain. What are the risk factors of subarachnoid hemorrhage? There are two types, like modifiable and non-modifiable. Modifiable risk factors are that can be potentially limited with intervention, like cessation of cigarette smoking, treatment of hypertension, abstinence from alcohol, cocaine, and antibacterial treatment or antiviral treatment of endocarditis. And of course, non-modifiable risk factors like polycystic kidney disease, connective tissue disease like Ehlers-Danlos disease, family history, arteriovenous malformations, and fibromuscular dysplasia. This one cannot be modified. And let's move on to pathophysiology of the subarachnoid hemorrhage. 85% are due to the rupture of cerebral aneurysm. And here on the right side we have a picture with location of aneurysm. Common locations are around circle of Willis, like anterior communicating artery, you see 40%, posterior communicating artery, they are 2 by number, and middle cerebral artery. Other causes of subarachnoid hemorrhage could be non-aneurysmal perimesencephalic hemorrhage, arteriovenous malformations, pituitary apoplexy. As a rule, the larger aneurysm, the greatest risk of rupture. The more likely it is to bleed. Symptoms that accompanying subarachnoid hemorrhage. Abrupt thunderclap headache is present in almost patient and is classically described as the worst headache of my life from patient. Headache lateralization is lateralized in 30% of patients, predominantly to the site of the aneurysm. And isochoria or pupillary asymmetry may precede bleeding if secondary to posterior communicating artery compression of the ocular motor nerve. Brief loss of consciousness and nausea and or vomiting can also be seen. Meningismus and lower back pain are common but are usually delayed several hours after bleed, since it is caused by the breakdown of blood products, erythrocytes especially, within the cerebrospinal fluid, which can lead to an aseptic inflammation of meninges called meningitis. Only 10% of people with abrupt thunderclap headache are suffering from subarachnoid hemorrhage. Other possible causes should be considered simultaneously as differential diagnosis, like meningitis, cerebral venous sinus thrombosis. Diagnosis of subarachnoid hemorrhage. There are many methods like non-contrast CT scan of the head, MRI, lumbar puncture, CT angiography, and conventional angiography or angiogram. Non-contrast head CT is a modality of choices. Sensitivity of the test is more than 95%, but decreases as the interval between bleed onset and seen. Especially on the first day after the onset of bleeding, it is considered a modality of choice. After 3 days, MRI may be more sensitive than CT scan and more precise. Lumbar puncture. Lumbar puncture is therefore regarded as mandatory in people with suspected subarachnoid hemorrhage if imaging is negative. So firstly, do CT scan after make a tap of the cerebrospinal fluid. Typically, 4 tubes of cerebrospinal fluid are obtained if there is an elevated number of red blood cells is present in all bottles. This indicates subarachnoid hemorrhage. If the number of cells decreases per battle, you are taking different battles, it is more likely to be due to damage of a small blood vessel during procedure, known as a traumatic tap. The cerebrospinal fluid sample is also examined for xanthochromia, or a yellowing appearance of centrifugated fluid. An interval of at least 12 hours between the onset of the headache and lumbar puncture is required for xanthochromia, as it takes several hours for the hemoglobin of the red blood cells to be metabolized into bilirubin and will take this yellowish color, as you see on the right side, and normal transparent cerebrospinal fluid on the left. CT angiography is used to visualize aneurysm. CT angiography is a quick and non-invasive test to identify and characterize an aneurysm. It is with contrast substance and help us to visualize the hemorrhage or just aneurysm, as you see on this image. And conventional angiography or angiogram can also lead to treatment like coiling or stenting by differing steps of procedure. And the newest method is represented by MRI, but it can only be indicated after 3 days after onset of headache. Treatment of subarachnoid hemorrhage: admission to neuro-intensive care unit. Clipping or coiling. Clipping requires a craniotomy or opening of the skull, also known, to locate the aneurysm, followed by the placement of clips around the neck of aneurysm. Coiling is performed through the large blood vessel or endovascularly by interventional neuroradiology. During this procedure, a catheter is inserted into the femoral artery in the groin and advanced through the aorta to the arteries of the brain, both the carotids and the vertebrals, as access vessel to the brain. Monitoring for vasospasm, also supportive care like hemodynamic management, maintaining of blood pressure at less than 160 systolic blood pressure, euthermia, euglycemia for preventing edema of the brain. Also for constant hemodynamic monitoring, stool softeners. Why? Because given to prevent straining. And bed rest is mandated until the aneurysm is secured. Analgesia is often given to diminish hemodynamic fluctuations, and deep vein thrombosis prophylaxis with pneumatic compression stocking. And the last line, complications of subarachnoid hemorrhage. Rebleeding, which is present in first 3 days after the initial bleed, vasospasm, delayed cerebral ischemia from vasospasm, intraventricular hemorrhage, hydrocephalus, syndrome of inappropriate antidiuretic hormone, left ventricular systolic dysfunction, subdural hematoma, seizures, and even death. Thank you for your attention.